Hello, everyone. My name is Corey Thornton. I am the Senior Editor with the Open Minds Market Intelligence team. I would like to welcome you to today's Circle Elite Executive Roundtable, developing innovative collaborations for school-based mental health services, the Emergence Health Network case study, featuring Kristi Daugherty, the Chief Executive Officer at Emergence. Before I hand it over, I have a couple housekeeping reminders. Your audio will be muted during today's briefing. However, we do want your questions. If you put them into the chat box on the right-hand side of your screen, Kristi will answer them when we get to the end of her slide presentation. And also the slides and recording for today's briefing will be available on the Open Minds website starting tomorrow. And with that, here's Kristi to get us started.
Hi, great. Thanks, Corey. And first of all, I would like to just thank Open Minds for giving me the opportunity to share our story with regards to our school-based mental health services here at Emergence. Let's see. We'll keep going through this. So a little bit about Emergence. We are the Mental Health and IDD Authority for El Paso County. The state of Texas has us set up in what they call authorities. And so we are considered an urban center, and we only serve one county for the most part. We are the largest international metropolitan community in the Western Hemisphere. So what that means is we have a kind of a triad here in El Paso, where we're in Texas, New Mexico, and Mexico. So we have a very diverse and dynamic community and population. We are the largest provider of behavioral health services in the region, and you can see some of the populations that we serve. That's just some highlighted populations. We are serving, ages 0 to 99 and in a variety different of capacities. We have, 19 locations, and we know we serve close to 38,000 folks a year. Right now, we're about a $64 million organization, a not-for-profit. And one of our priorities over the years have been to partner to increase access and increase availability of the needed services in our community. So one of the things that we've done is really targeted working with our school districts, educational service centers, which those are in Texas are service centers help districts with student performance, special projects, making sure the school districts are working in the most efficient and economic way. So we partner with them, all of our not-for-profit agencies in our community, as well as our pediatric medical providers, because as you know, children's services are critical for a child, or children's mental health services, excuse me, are critical for a child's success. So starting out with a little bit of history on our journey to get where we are today with regards to our school-based services, we decided to approach our largest school district, which is El Paso Independent School District, and discuss the possibility of an agreement for campus-based services, and really coming at it from an access perspective. So as anybody probably knows, going to a doctor's appointment can be very time-consuming, where you have to take a day off work, pick the child up from school, sometimes drive across town, or in rural communities, maybe drive to another community in order to access services. So our target was really access, but you got to approach it from a win-win, to where what is the district's win? Well, they really want to make sure kids are in school every day. So reducing absenteeism, reducing incidents on campus. So EPISD was excited and engaged with us to be able to enter into what we started out with was a memorandum of understanding. And the reason we did that is because we weren't going to have any money exchanged, and I'll get into that a little bit in a minute. But we took time to really go through our model with the administration so they felt comfortable. And then we also researched some other models to make sure we could, implement some best practices, tailor them to our community. And so we wanted not only to look at access to services for the students, but how can we also offer training opportunities for faculty? Because as you know, teachers are with the kids awake more sometimes than parents. And so how can we empower the faculty to be able to address issues and provide support? And then also engaging parents and getting parents involved in the mental well-being of their child. So some of the lessons learned, our situation was a little unique. We started this right before March of 2020, which everybody knows what happened to our world that month. So we actually got the agreement approved in April of 2020, which was not the best timing because most students were at home. They were learning from home. So what we decided to do is take that time to start building a model, creating trust and the relationships, because you can work at the administrative level, but once you get into the schools, they're kind of their own little countries with the principal and the assistant principal, the school counselors. Everybody has a different way of doing things. So you have to adapt and adjust as you go into each individual schools. Again, what I had highlighted a while ago, there were no costs to the district. So we came at the district and said, look, we are already serving these kids in our clinic already. We were able to run a zip code analysis and demonstrate to the district, these are the numbers of children we're already serving. So what if we were able to provide a more convenient point of access for the families? So what we did is we targeted 5 schools, 4 high schools and a middle school. And we said, let's start here because that's where the zip code saturation showed, the zip code analysis showed us the saturation. And then we can also serve the feeder schools. So the feeder pattern into those high schools, we also can serve at that same site. Very appealing to the district because, again, it didn't cost them money and we were going to provide support to their faculty and staff. One of the things you'll run across is you have different, HIPAA and FERPA, different types of regulations regarding information sharing. So our documentation is completely separate. We keep our own electronic health record. That way there's no confusion on who owns those documents. I'll go through a little later some of the process because, of course, consent is extremely important. But one of the things we did have to work very hard on is delineating the difference between crisis care and traditional services, outpatient services. Because a crisis, if a child is in crisis, is very different than a child seeking therapy or things like that. So again, like I said, we went through zip codes. We went through a lot of work on definitions, defining what is a crisis. What is a crisis to the campus versus what do we, as the mental health provider, define a crisis? So that took some work, but we got to a good spot with regards to the need for consents for certain types of services. And so we did have to jump through some hoops and some hurdles to help the district and the campuses understand if a child is in a true crisis, we are not going to wait to get consent from the parent. We're going to ensure that child's safe. And that's worked out very well up to this point. We've been very successful. Some of the services offered at our school-based locations are counseling, skills training, and case management. So we are making sure we're linking the child to services. Sometimes there's a need for food or housing, things like that. So we are working those angles with our case management. We are, again, solely operated separately. We are billing for kids that are covered by Medicaid or an insurance. We are billing those services ourselves. We are very clear about that EPISD is not requiring a student to receive services from us. So there's no mandatory, you have to go to Emergence, but we do make sure that we are keeping the districts and the campuses educated on what we offer and what we can do. If a child's receiving services from another provider, we also make sure that that provider is involved if something happens at school. So a little bit about the process. So we really take referrals from different places, and I'm going to go through that in just a minute, but we do an assessment. Really, what's going on with this child? What are the needs, strengths? We do develop an individual plan, and the district does participate in those meetings. The school counselor typically participates in those meetings, of course, with consent signed. We are always looking to see what community resources this family could benefit from. How can we ensure the student's success, both from a mental well-being perspective as well as an academic perspective? A treatment plan is developed, and then we are always monitoring and reassessing to make sure those needs are met. Again, the constant coordination of services and communication is so critical, because we have to, as the provider, and you can look at yourself as a guest on campus, you need to make sure your host, the administration or the school district, is always informed and they feel comfortable with the process. And that was what we used the time that the students were remote. We used a lot of that time to create those processes and, you know, the trust and the relationship building with the campus personnel. So with regards to a referral process, you know, every school district may want to be a little different. We are currently in 3 school districts, 1 large, and then a medium-sized district and a very small rural district. So we really leave it up to the campuses and the district on how they want to identify and who is able to make that referral. So of course, the student could be identified from a teacher, parent, school counselor, you know, different things like that. So our large district, they do require the referral to go through the school counselor, and that's fine. And we want to make sure that that process is adhered to and supported. In our smaller districts, the district is allowing anybody to make a referral, whether it be a counselor or a teacher, administrator. So it really does depend on your district. The referrals are very, very basic, you know, just demographic information of the student, demographic information of the family, a little bit about what the issue is. And then we have a very easy to use referral form that's a checkbox form, to where it doesn't take a lot of time. And then that comes over to the EHN staff, and then we then ensure that it's an appropriate referral. And then we have a really unique way for the consents to be sent through the school counselor, again with our large district. I'm going to show you that here in a minute. We use technology to do that, so it's not a paper process back and forth. If the parent approves, then we move on to the referral and moving through our centralized scheduling department to make sure that we are keeping track of all students served. So even though the services are happening on a school campus, we schedule that and we do everything through our centralized scheduling department to make sure that we are getting the right information and the appointments are in our schedule and adhered to. If the parent says no, once the school counselor sends that over, then we simply give the parent some resources, our crisis line. Please, if you change your mind, this is how you get a hold of us, or go back to your school counselor. So again, this is for a traditional non-crisis referral. Looking at the referral form, again, it's a very simple form. It's nothing too difficult for a faculty or staff to fill out. And then what we've decided to use is we use these QR codes. So the QR code can be sent to the family through the school counselor, where they can just pop that open and there's the consents, and those consents come right back to us. So it makes it very easy, not having to send something in a backpack to where it gets lost. And then our screening form is also done through a QR code. And this is completed by the school counselor as well, to where it's very simple and automated, to where things aren't lost. We keep track of all the information that is being provided to us by the school or the family. So really easy to do. We use our QR codes across our system, but something to think about, and it's not a difficult or a hard task. So that really wrapping up with our on-campus clinics. You know, we are serving right now so this school year we've served over 200 students. The major diagnosis that we see is major depression, anxiety, and adjustment disorder is on the top 3. But one of the things that's really exciting is in this school year we have trained over 4,000 faculty, staff, and parents in different things. I know one of our successful trainings we've had recently was on vaping. And so the majority of those 4,000 are faculty. We are a mental health first aid provider, so we do that as well for the school districts if they want to do that for their teams. And so a lot of wonderful things have happened. Our first year was a little bumpy because we were coming back after COVID, and of course the priority for the school districts was reintegrating the kids back into the school, but that also raised some levels of anxiety with kiddos and things like that. So we were able to work hand in hand with the districts on reintegrating those kids back. This year we've had a little bit different approach with regards to the actual referrals for the different diagnoses that I shared. I've had some great feedback from families and school counselors about how they're grateful for the program. One family in particular, we had a child that was coming from Mexico to come to school in the United States, and it was a big transition, and we were able to help her be successful in that. So we were very excited about those outcomes. So shifting over to a crisis response or a crisis model, we are actually providing school-based crisis intervention. Many of you may already be providing a CIT model where you have a partnership with your local law enforcement, where a clinician might be in the police car with a specially trained officer, different models throughout the country. What we've done is we've partnered with 2 school districts that have their own police force. So we're very excited to be able to provide this service at 2 of our districts, a large district and a medium district. A little bit about CIT, if you're not familiar. It is a partnership with law enforcement and mental health. We also have CIT with our city police, our sheriff, several of our some of our rural counties around. We partner with those law enforcement teams as well. Again, it's a partnership. But what's unique about this is this partnership that I'm going to describe is actually with an ISD's police force. So what we do is we are really trying to avoid kids that go into crisis going to jail, emergency rooms, trying to get them linked to services so they don't have this crisis again. We definitely are reducing the use of force, and that is a goal of CIT as a whole. And then again, getting them the services they need. Clearly something's going on, and so let's try to get them the services they need. And embedding your school district police force helps your districts feel a little less uneasy about that liability when it comes to a crisis. So our school-based CIT, again, we are in our El Paso Independent School District, and then we're also in another district which is a little bit smaller. We have 4 CIT specialists, a therapist, and then a program manager. Our therapist and our program manager both are licensed clinicians. We are available through 7 a.m. and then into the evening or the afternoon because things happen after school, 5 days a week, including holidays. So what this is the school district police force will call this team, and then we meet them at the school that's having the situation. We are not in the police car with the school district police force. It just isn't a good use of resources. This district or the school-based CIT can respond to a student. They can respond to a faculty member or staff, but also if a parent is on campus having a crisis, we can also help there. So there's a couple of ways we look at this through emergent versus urgent calls. So an emergent call is going to be something that is requiring a 911 response. A student has escalated, or a parent, faculty has escalated to a point of suicidal intent or homicidal intent, making threats. So this is an urgent or an emergent response where we're there within an hour. An urgent call is where a student hasn't escalated to that point, or the person that's involved, but is in crisis. So we can get there within that school day. But I can tell you, we typically don't take 8 hours to respond. We're there within the hour or a little more than an hour if it's an urgent call. How we dispatch. So again, the administrator is going to, or the school counselor are going to get their ISD police force involved, and then they request a CIT assistance that comes into us. The police dispatcher then calls us and says, whether it's an emergent or urgent call, and then we then deploy to that location and help, whether, you know, students, whether they're involved in special ed, behavior mod, anything that's going on with that student, we'll be able to help out with. And I've had some really amazing outcomes to where Child Protective Services is on campus, the parent is there, the student is extremely anxious or really they won't engage with anybody, but our CIT specialist is able to go in and really step in, engage with that student, and make a difference to where that student is safe. So that is the presentation that I have today. Again, two really wonderful programs that have had amazing success here in El Paso. We're looking to continue to grow both with our rural and our large districts, and also continuing to add CIT where it's appropriate. So thank you for the time, and thank you for letting me share our story today.
Thank you very much, Kristi. I want to remind everybody, any questions that came up during the slide presentation, please, you can drop them in the chat and we will address them. I'm going to get us started here. And yeah, Kristi, could you explain the relationship piece of this project a little bit more? You know, helping your districts understand the separation of responsibilities comes to mind. You know, defining the roles. How do you approach those conversations? And you know, how hard is it, especially for an organization that maybe is starting this fresh? It sounds like you had a lot of connections in the community, but if somebody says, you know, we want to expand our connections in the community, you know, how would you advise they go about that meta leadership aspect of this work?
Well, it's important to bring something to the table. I think that's what I wanted to really highlight today, is that we brought something to the table and said, okay, El Paso ISD, this is what we can do. And then it's, and not saying, but you have to pay us to do it. So I think that really opened the door. And the superintendent, and just to a little backstory, we actually had a superintendent change right after we signed our agreement. So we had to kind of start over to be able to gain the new superintendent's trust. So it's about trust. It's about that collaborative approach. What can we do together? But I think once we got into in the door and everybody was like, yeah, this is a great idea, let's move down the road, it was really important to define our roles, because you don't want a school counselor feeling that they have to provide mental health counseling if that's not within their scope, but also knowing our role and where we come in, because one of the things we don't do is if it's just a child refusing to go to class, we're not going to get involved in that. That really is a district and they need to take care of that. So there's definitely some you got to be clear on your role, and then defining things, because our definition of a crisis and the school district's definition of a crisis was different. So we had to come to an agreement on what that was and the responsibility of each entity. But the big thing is to open that door is coming in with something to offer, and not saying, you know, this is going to be something you have to pay us for.
So you mentioned some of the challenges to this work previously with me, and question for you, you know, if you could dig deeper into, you know, these hurdles. You had mentioned liabilities and defining things. You just talked about defining things. You know, can you talk about the liabilities a little bit and what you guys have to keep in mind as you progress interacting with this community?
Well, for the traditional services, I went through the consent process, and that's non-negotiable. You have to go through that. Where we had some hurdles and where we had to really work through some things is more on the crisis side of things. One school wanted us to, if a child was in crisis, we have to get parent consent before we interact with that child in crisis. And we were like, that is really not in the best interest of this kid. So we really had to just go through a lot of scenarios and helping the district understand, if the child is in crisis, we can come in and help that child and get that child safe. It would actually reduce the liability on the district versus increase the liability, with the understanding that we have this MOU in place. And the MOU really comes into place about information sharing, the business associates agreement, things like that, especially when it's a crisis.
Okay. So you mentioned the difficulty, you know, building the trust of the community, building the trust of these schools and the administration. You know, I kept thinking you kept saying coordinate the care, which I know a lot of organizations have problems with across different markets. You know, what has proven essential to make sure that care coordination happens?
Well, I think our relationships outside of the district, because we have really solid relationships, you know, with other non-for-profit providers, with our hospitals, if we have to move a child, unfortunately, into a hospital. And I can tell you of the kids that we have provided services, crisis services for, less than 1% have been hospitalized. We've really been able to get those kids into care in the community. But I think really you have to make sure you have a network that can respond. You can never predict every single situation that you're going to come across. But like I said, the Child Protective Services situation, we already had a standing relationship with our CPS. So when we get there and somebody's coming in with an Emergence Health Network badge, they trust us. They know we're going to do what we say we're going to do. Get this child or this family resources, services to where the child is safe. And so that's, of course, CPS's main goal. And so really, again, it's just inserting yourself into different situations or different meetings. You may not be a traditional place you go, whether it be with law enforcement or not-for-profits. Some of our support services for like housing and food, because sometimes that we drill down and that's the issue. The child the family doesn't have anything to eat. And so really having that network established or on its way to being established, to where when you run across a situation with a student, you're not scrambling to try to find something for that family and student.
So, what's the future of this kind of a program? And I kind of ask because everything you've said right now sounds like, not quite like, but similar to whole person care. These kids, you guys are really touching them in their lives in a lot of ways. What's the future for this or similar programs that you may have in mind?
Well, one of the things we're working on with our large district right now is adding the medical component. So allowing the student to be able to be seen by a medical provider, whether it be a psychiatric nurse practitioner or a psychiatrist on campus through some sort of tele platform, telehealth. So opening up that as our next step, because again, really making sure we're addressing everything the child needs at a place, one, they feel safe, it's familiar to the family, and it's close to home typically. So that is our next step as far as implementing medical services. And then again, just really trying to expand into, we have a lot of rural districts around El Paso. We're a large city, but we have little communities around that surround us. And so really tapping into those smaller communities, because resources are so scarce. Driving an hour to get to our doctor's appointment is very difficult. And so we want to make sure our outlying communities and our rural school districts have support.
So I know this because Open Minds has worked around Emergence quite a bit in the last couple of years. We know you've done a lot of investment in technology. And we didn't talk about technology during your slide presentation, but any organization that would like to set this up, in addition to the relationship building, tech sounds like it's a big part of what you guys do. Can you explain, for an organization starting semi from scratch, what's the tech infrastructure they're going to need to build to make this run smoothly?
Well, I think, again, the pandemic accelerated many of our ways of providing care into the technology space. Fortunately, Emergence was already in that space. We were already moving down the road of telehealth and different types of way of accessing services. But I think what we did is, you really have to make sure, again, if you're going to go to a school district, you can't not be ready for that request of some sort of technology, whether it's embedded in your electronic health record, which we are working on that option right now with our vendor, whether you're using an outside, some sort of a HIPAA compliant protected platform. We've used one of those as well. Having mobile technology, not expecting it to be on a desktop. I joke, we have iPads on a stick. I joke with that because they are just iPads on almost like an IV cart, where we can roll them around the schools to where we can get where we need to be at the time they need us. And so there's just different ways you have to do it. But the other side of it is, I can tell you, during COVID, as we were going through this, because we had started this relationship with the district, we were able to ask them to allow our services, our platform, access on the school issued equipment. So we had kids at home. Sometimes that school issued laptop was the only piece of technology the family had. And so our kids were able to see their provider on their school issued laptop, because most of the time the school really, they govern what kids can put on those devices. So that was something else that we did to be creative during COVID that has moved us into that relationship and that trust with the district on technology.
From start to finish, how long did it take you guys to launch this?
Well, because of COVID, we had a nice 2-year kind of extension. What took some time at the beginning, it took several months. I would say probably about 6 months to get the MOU worked out with legal, because you have our legal, you have their legal, the district, things like that. So that took about 6 months. And then we had a whole year, because the kids were remote, that we weren't able to do the on-site, but we were getting processes in place. But then the next year was another kind of that reintegration year that we supported the district in. And then this school year, starting this past fall, has been our first full-fledged go at it. But I think the build-up helped us, again, build those relationships. So if you take out the pandemic, it took us about a year and a half, or about a year with the different things that we had to do. But we were stretched a little longer, and again, we tried to make the most of those times.
Okay, so from a financing standpoint, I guess I have 2 questions. Budgetary wise, how big a lift was this to get this in place? And could you just break down the financing one more time for me, the way you guys bill?
Well, the way we approached it at the onset was, we have staff that are already providing services to these students in your catchment area, in the school's catchment area. So what we wanted to do is just rehouse that staff. So our ask to the district was, give us space and we will provide the care. So at that point, it was really a no-cost relationship. We have been very fortunate to receive some SAMHSA dollars around school-based mental health. So we were able to grow the program somewhat through that. But then again, we bill. I think that's the thing, is you have to have a mechanism to bill in the, we use a community code to where you can bill the services as a community-based service. And that's happening in the school. So make sure you do that upfront intake to get Medicaid information or insurance information. So we've done that. But as far as finances being exchanged between us and a district, like our money being exchanged between us and a district, that has not happened. Everything has been done. They provide a space. They give us access to different things. We then provide the care either through our grant that we were very fortunate, but most of our kids have Medicaid. They have some sort of coverage, and so we're billing that. On the CIT side, we did get some money from a couple of sessions ago in Texas for diversion. And so we're able to use that diversion funding to fund our CIT team, because we are truly diverting children from hospitalization, jail, or inappropriate care, or inappropriate levels of care.
So that leads to my next question. Do you have any outcomes that you might be able to share with us, or may have in the near future?
Yes. Well, the data, I think what I was sharing with you is, right now we've got a little over 100 kids that we've served with our CIT program. I can start with that. And of that, less than 1% have been hospitalized. Most of them are discharged to families, or, we call it a discharge, but we release them to the family with services. And then some of them we've actually just gone to the parent and relink them back to their provider, not being EHN, which we're totally good with. The other thing that I forgot to mention, one of the things we do is we do a quarterly report to the district, broken down by campus. So we're able to show them exactly where the services are happening, the number of kids served, the number of trainings we've done. And like I said, we've served a little over 200 kiddos in our clinic based this year. And then the big thing that has happened this year, I think, is that step into the campuses is the training, where we've actually served over 4,000, whether it's parents or faculty, in trainings, different types of trainings. And so I think that's important, because those teachers really need to be armed. And what we're trying to do is get that mental health first aid in all of our districts. Even if we're not on campus, we're trying to train as many teachers, school counselors, bus drivers, cafeteria workers in that mental health first aid curriculum, because that helps so much when something does happen.
Okay, so it sounds like you have good outcomes. You are touching on a little bit of whole person care, social determinants of health. You are all over the community. Does any of this in the future maybe change the reimbursement discussion? And I know you're.
Oh, sorry, Corey. It's interesting you asked that because there's actually a bill right now. If there's anybody listening from Texas, there is a bill being considered right now in Austin to allow schools to bill Medicaid. So there's some concern around that from different people. And so would that change our role in the district? Probably not with the district we're established with, because they are comfortable with us and we bill the service to Medicaid. But if a district is allowed to bill Medicaid for services, not just behavioral health, then they could want to do it themselves. So only concern I have with that is making sure you have the qualified staff, because school counselors are not typically trained to be therapists. They have a different type of background. I think they're wonderful at what they do, but they aren't necessarily therapists. So I think we have to keep that in mind in Texas. I'm not sure about other states. But I think really if you can establish some data to your manager, because most kids in El Paso, I should say, are covered by Medicaid. If you could establish some data on keeping them in the home, keeping them out of emergency rooms and the more expensive types of care, you can go to your managed care companies to set up some sort of value-based reimbursement, risk sharing, saying, hey, we're serving these kids in the schools, can we get an enhanced rate, or can we get some sort of something, you can talk to them about, the incentive based, because you're serving these kids where they need to be served, not waiting for them to go into crisis.
Is there any likelihood that Emergence may take that approach in the coming years?
Yeah, I do believe we have really good relationships with our managed care companies right now. They're very good partners. We do have some risk sharing or some value-based agreements on other things. So I think once we can get some good baseline data, even this full school year, we can sit down and have some conversations.
Okay. So speaking of the schools, convenience sounds like it's really critical to the work you guys are doing in this model. What are some of the ways on the ground that you make sure that it remains convenient for the educators, convenient for the counselors, convenient, most importantly, for the children?
Well, the big thing is the ease of making a referral. You have to make it easy. And I think I showed you those QR codes are very handy. Most everybody has a smartphone these days. They can pop those open. So I think making things as efficient and the ease of that as possible. And then really that communication with your district. Because, you can successfully serve 500 kids and have one not go right, and that causes things to, people to get uncomfortable. So you just really have to communicate. You have to constantly take feedback on, is this working? Is this process working? What can we do to improve it? And so we actually have a liaison to the district that works directly with our program folks to constantly, they talk at least once a month. They have a meeting once a month. What's working, what's not working. And so you have to it's a constant process improvement feedback loop, constantly talking about what's working, what's not working. And then, this is basic, I think, customer service, doing what you say you're going to do. I think that's the most important thing. And I think we've been successful at that.
Well, I was going to kind of give you a chance to wrap up with one of the top 3 things that our attendees should know. And I don't want you to have to repeat yourself, because that was a nice little summation you just gave us. But I'm going to ask anyways. What critical to setting up this kind of a model? What do you think an executive who wants to bring something like, we want to expand into this, goes to their board or their executive team? What should they have in that conversation?
Well, I think the biggest thing that, and I approach all situations like this, are new endeavors, is what do we have? What do we have to offer? Because I think everybody thinks school-based mental health is a great idea, but you have to go in. It's a bargaining. What do you have to offer that district? And so make sure you're confident in what you have to offer. Make sure it's something that is sustainable and that you can have long term, because you sure don't want to get into a district and then say, oh, dang, this was a grant funded program, sorry, we have to close it down. You never want to be in that situation, because that really tarnishes your reputation. So I think being confident in what you have to take to the table, and that way when you try to open up those doors, you come in with something to offer. And I think that's most important.
That sounds great. Thank you, Kristi. I think we're going to wrap it up a little bit early today, but this has been great. If you could advance me a couple slides there. All right, well, everybody, I want to thank you. I want to remind you that the slides and recording for this will be up on the Open Minds website tomorrow, and potentially as early as next week, we will have a more in-depth article talking about our discussions today with Kristi. The full Circle Elite Executive Roundtable series is also available on demand as part of the extensive Open Minds library. We will be off for a couple weeks, but we'd like you to join us on Thursday, April 20th at 1 p.m. Eastern Time for how to radically re-engineer your service portfolio, creating innovative new options. That is part of our CFO consortium and will feature Thomas Grant, its CFO for Wooden Services. A full list of upcoming roundtables is also available on our Open Minds website at www.openminds.com. Kristi, this has been great. Thank you very much for sharing with us, and I hope you and everybody on the call today has a wonderful day.
Great. Thank you so much.
Take care.